Okay, so welcome to this next video in which we are discussing the acute inflammatory response and anti-inflammatory drugs. Okay, so we have so far seen antihistamine drugs and also drugs which have targeted tumor necrosis factor alpha. So these are two of the pro-inflammatory mediators which kickstart the whole acute inflammatory response. Now let's look at drugs which target the final one. So the final pro-inflammatory mediator is interleukin-1. So remember, when a pathogen is present within your interstitial fluid, it will be detected by sentinel cells, and there are three major types of sentinel cells: dendritic cells, macrophages, and mast cells. When the mast cells detect pathogens, they release histamine, which goes on to cause type 1 activation of endothelial cells. When dendritic cells and resident macrophages detect the pathogen, they release tumor necrosis factor alpha and interleukin-1, which both go on to cause type 2 activation. Okay, so the interleukin-1 will be released from these cells. It will diffuse over to the endothelial cells of the blood vessels in that local area, and it will bind to the interleukin-1 receptor on the surface of these cells. Okay, so this is the interleukin-1, specifically the type 1 interleukin-1 receptor, so interleukin-1R1, okay, for interleukin-1 receptor type 1. So I think I'll colour it in red, I think. And this will kickstart a pathway which leads to the formation of a signalosome and then the activation of the two transcription factors NF-kappa B and activator protein 1. Okay, so it'll lead to type 2 activation overall. Now, there are two drugs that I want to talk about which take out this pathway here. Now, one of them is a competitive antagonist for the interleukin-1 receptor type 1. Okay, so this will sit here. So it will come and bind to this receptor, and it won't do anything to the receptor, so it won't activate the receptor, but it will just block the interleukin-1 from being able to bind to the interleukin-1 receptor type 1. Okay, so that's what a competitive antagonist does. It does not inhibit the receptor, it stops the activation of the receptor. And there is a distinction. There are drugs which do actually inhibit receptors, and those are known as inverse agonists, not competitive antagonists. The strict definition of a competitive antagonist is something which binds to the receptor, does absolutely nothing to the receptor, but stops the activating ligand from being able to bind. And there is a drug which does this, and it's known as anakinra. Okay, so anakinra. So this is a competitive antagonist for interleukin-1 receptors. Okay, and it will bind to that interleukin-1 receptor type 1 and stop the interleukin-1 from being able to activate it, and that will stop the type 2 activation of the endothelial cells that occurs because of interleukin-1. And therefore it will hugely reduce type 2 activation and thereby hugely reduce the acute inflammatory response. Okay, now there is another drug which is similar to etanercept. It's a very similar concept, that what you make is a recombinant interleukin-1 receptor, and you make it so that it's soluble, okay, and then you give this to the patient, and it will go and bind to the free interleukin-1. And once it's bound to that free interleukin-1, nothing happens, but the interleukin-1 cannot now bind to the interleukin-1 receptor 1 on the surface of the endothelial cells, okay? So it's basically sequestered and used up. So you're effectively mopping up the interleukin-1 and stopping it from being able to activate type 2 activation. Okay, so what's the name of this drug which does this? Well, it's known as rilonacept. Okay, so this is rilonacept. Okay, so rilonacept is a interleukin-1 receptor that has been made soluble and is therefore free and will bind to interleukin-1 and mop it up effectively and stop the interleukin-1 from being able to activate the interleukin-1 receptor type 1, and thereby stop a huge amount of type 2 activation. Okay, so these all make huge sense, basically. They are targeting the initiators of the acute inflammatory response, and thereby they're going to have very powerful anti-inflammatory effects. Okay, so the next drug I want to talk about is a drug known as icatibant. Okay, now this is another competitive antagonist for a receptor. Now, which receptor is it actually a competitive antagonist for? Well, it's actually a competitive antagonist for the bradykinin 2 receptor. So, the bradykinin 2 receptor is a receptor on the surface of the endothelial cells, okay, which is GQ coupled, and therefore, if it becomes activated, will cause type 1 activation. Okay, now the ligands for the bradykinin 2 receptor are bradykinin and calladin, which, remember, are molecules that you will create via the kallikrein-kinin system. So when the inflammatory exudate is formed, then you set off the kinin cascade, and the two end products of the kinin cascade, or the kallikrein-kinin system, is that you get bradykinin and calladin being formed. These then diffuse back to the endothelial cells and have a positive feedback effect and trigger further type 1 activation, as well as going and activating sensory neurons and causing pain. Now, icatibant will bind to B2 receptors. Okay, so they'll bind here, and it will stop calladin and bradykinin from being able to bind. So it's again a competitive antagonist. It will bind to the receptor, and it will do nothing to that receptor. It won't activate its catalytic activity with regards to the GQ heterotrimeric G protein. All it will do is stop the calladin and bradykinin from being able to bind to that receptor, and therefore it will stop them being able to cause type 1 activation of endothelial cells. So it will take out this very powerful positive feedback loop within the inflammatory response, basically, okay, whereby type 1 activation causes more type 1 activation, causes more type 1 activation, etc. Okay, and it really stresses how important the kallikrein-kinin system is, that icatibant is a very effective anti-inflammatory drug, and just by killing that positive feedback loop, you can have an anti-inflammatory effect. Okay, so that's another competitive antagonist. Okay, so we're going to now move on to a very different class of drugs, but a very famous class of drugs. So all of these have been about stopping the effect of certain products, certain molecules. Okay, so we've seen things that stop the effect of histamine, stop tumor necrosis factor alpha, stop interleukin-1, stop the bradykinin and the calladin. Now what we're going to do is see things which stop the production of prostaglandins, and specifically we've looked at prostacyclins, so they're going to inhibit the production of prostacyclin. Okay, so these are the non-steroidal anti-inflammatory drugs, and these are famous drugs. These are the drugs that you will have actually heard of before ever going to medical school. Okay, so non-steroidal anti-inflammatory drugs. And you might think, well, why didn't he present these right at the start? Why did he go through these more niche things that no doctor would ever just prescribe you unless you had some serious illness? Well, the reason is that these ones, I think, are the natural ones to talk about first, because they really are taking out the initiators of the acute inflammatory response, which, if you were to actually sit down and think, how are we going to kill this system? This is what you'd come up with. You'd come up with things that block tumor necrosis factor alpha, interleukin-1, and histamine, because they are what start it all. Okay, so that's why I think it's more natural to talk about those first, even though these drugs are more famous. Non-steroidal anti-inflammatory drugs. Okay, now their name is a bit of a mouthful, so they're often abbreviated to the NSAIDs for short, the NZs as they're called. Okay, so What do these drugs do? Well, in fact, let's talk about the famous examples first. So this is just reciting drugs that you know the names of. Ibuprofen is a non-steroidal anti-inflammatory drug. Aspirin is a non-steroidal anti-inflammatory drug. And I really think we should know the structure of aspirin because it's very simple and you all have made it at some point. So aspirin is also sometimes called acetyl salicylic acid, so salicylic acid, and for that reason it's sometimes abbreviated to ASA for acetyl salicylic acid, ASA. Right, so what's the structure of acetyl salicylic acid? Well, let's start off with what the structure of salicylic acid is, because aspirin is just going to be an acetylated version of salicylic acid. So salicylic acid then, you have a benzene ring as the starting point. So here is our benzene ring here. And then you have a carboxylic acid group coming off the benzene ring. Okay, and then just one more group. You have an alcohol group coming off it. So this is what is known as salicylic acid, which is often abbreviated just to SA for short. SA. Okay, so it used to be used as a painkiller and also as an anti-inflammatory drug. It does have a similar effect to aspirin. However, it's got horrible gastric side effects, so it's no longer used as a replacement for aspirin. It's what's in willow. It's the more natural compound. Acetyl salicylic acid is the modified form of it that we've made, which is more tolerable by the body. It's less poisonous. Okay. Salicylic acid is still used to treat certain skin conditions. It's used to treat things like acne. It's a topical treatment for acne. Okay, what else can I say about it? So, how do we convert it into acetyl salicylic acid? Well, we stick an acetate group onto the salicylic acid. So, basically, here is an acetic acid molecule, which is the old name, remember, for ethanoic acid. So here comes our acetic acid molecule, and what we're going to do is form an ester link between this carboxylic acid group of the acetic acid molecule and this alcohol group of the salicylic acid molecule. So we're going to take that whole alcohol group off the carboxylic acid group, we're going to take the hydrogen off the alcohol group, okay, there, and we're then going to bind that oxygen which remains to that carbon here, okay? And that will form our ester link. That will create us acetyl salicylic acid. And like I said, I think you will have made aspirin at some point. It's something that usually most people have done at some point. Okay, now, these two drugs are the most famous non-steroidal anti-inflammatory drugs. And they are what are known as non-selective cyclooxygenase inhibitors. Okay, so they both inhibit cyclooxygenase enzymes. And which cyclooxygenase enzymes? Because we've seen two now. Well, they're not selective for either of them. They will inhibit both of them. So they're non-selective cyclooxygenase inhibitors, and they're going to inhibit both COX-1 and COX-2. Cyclooxygenase inhibitors. So these drugs go inside the cyclooxygenase enzymes and stop them from working. Okay, so we're going to take out cyclooxygenase 1 and cyclooxygenase 2, and that will completely stop the production of prostaglandins. So remember, if I get my pictures, where have I got cyclooxygenase 1? So remember, in type 1 activation, cyclooxygenase 1 was constitutively expressed on the surface of the endothelial cells, and when you started getting arachidonic acid appearing in the cell membrane of the endothelial cell because of the activation of the cellular phospholipase A2, then it will convert it firstly to prostaglandin G2 and then to prostaglandin H2, and then the prostaglandin H2 is used by prostacyclin synthase, which is in the membrane of the endothelial cell, is in the membrane of the endoplasmic reticulum. It will convert it into prostaglandin prostacyclin, okay, and then prostacyclin will be released by the endothelial cell and will cause relaxation of the vascular smooth muscle cells, and therefore vasodilatation, increasing the blood flow to the area. Now, in type 2 activation, you then create a bigger, better version, which is cyclooxygenase 2. Okay, and cyclooxygenase 2 does the same thing, but it's better at doing it. It does it far faster. So it converts arachidonic acid into prostaglandin G2 and then into prostaglandin H2, which is then converted by the prostacyclin synthase into prostacyclin, which will be secreted from the endothelial cell. Okay, so if you give one of these drugs, aspirin or ibuprofen, they will block those two enzymes completely and therefore completely stop the conversion of arachidonic acid into prostaglandin H2. And if you don't have any prostaglandin H2, then the enzyme prostacyclin synthase has no substrate, therefore you don't produce any prostacyclin. And prostacyclin is very important for producing the vasodilatation of the terminal arterioles that increases the blood flow to an area. So, if you give one of these drugs, it's going to stop the increased blood flow to an area. Now, that's going to stop the redness and the heat associated with the inflamed area, so it's going to stop rubor and calor. But you also have to consider that if there's less blood flowing through the affected area, then it's also going to mean that there is less blood to produce the inflammatory exudate, and also there's less blood to supply the leukocytes in. Okay, so you're also going to take down the tumour, the swelling, and also if there's less inflammatory exudate, then you're going to have less of the proteins from the blood coming out into the area, and this will slightly reduce the kallikrein-kinin system, so you might also get less bradykinin and calladin being produced, and therefore less pain and less loss of function. However, the reason that these drugs are powerful analgesics, i.e. they also reduce pain, is different. The reason they stop pain is that they stop the production of another prostaglandin known as prostaglandin E2, which we haven't discussed. But prostaglandin E2 is also synthesized from prostaglandin H2, and that's the reason that they produce the analgesic effect. But the anti-inflammatory effect comes mainly from them stopping the production of prostacyclin. So we're not really focusing on killing pain. We'll do a whole playlist on pain later. But we're focusing on their anti-inflammatory properties, and the anti-inflammatory properties are because they stop the synthesis of prostacyclin. Now, these two are non-selective cyclooxygenase inhibitors. They stop cyclooxygenase 1 and cyclooxygenase 2. Now, this isn't great because in the stomach, cyclooxygenase 1 is very, very important, and if you inhibit it, it can lead to horrible gastric bleeding and gastric ulcers, so it's not nice, basically. Okay, so it was thought, wouldn't it be a brilliant idea if we could make a drug that was selective for cyclooxygenase 2, i.e. a drug which only inhibited cyclooxygenase 2, because cyclooxygenase 2 generally is not expressed in tissues of the body. It's not a normal enzyme to have expressed. It's usually only produced within endothelial cells when there is the inflammatory response going on. So it's part of the acute inflammatory response. Now that rule turns out not to be completely true, and this really is the downfall of cyclooxygenase 2 inhibitors. However, there are drugs which just inhibit cyclooxygenase 2, and an example is celecoxib. Okay, so this just inhibits cyclooxygenase 2. So this circumvents the gastric side effects, because if you don't inhibit cyclooxygenase 1, then it's not so damaging for the stomach, because the reason that aspirin and ibuprofen cause nasty gastric side effects, and ibuprofen and aspirin, they are nasty drugs. You mustn't take them too much because they can cause gastric bleeding. Okay, but the reason for that is they inhibit cyclooxygenase 1. So if we just had a drug which inhibited cyclooxygenase 2, then okay, it wouldn't stop the cyclooxygenase 1 of type 1 activation, but that was, it was a pathetic little enzyme anyway. So we're going to still kick off this cyclooxygenase 2 here, so we're going to wipe this out, and therefore we're going to stop arachidonic acid being converted to prostaglandin H2, and therefore we're going to reduce prostacyclin synthesis hugely, because remember, cyclooxygenase was really slow, cyclooxygenase 1 was really slow at converting arachidonic acid into prostaglandin H2. It was cyclooxygenase 2 that was fantastic at doing it. So if we inhibit cyclooxygenase 2, then it should still have a decent anti-inflammatory effect, but hopefully it would have less side effects. Now these drugs, unfortunately, they haven't had much of a success story. We hoped they would have a fantastic success story, but the reality is that they don't have a very good record. There was a drug known as rofecoxib, which was a selective cyclooxygenase 2 inhibitor. It's also known by its brand name, which was Vioxx, okay? And in 2004, 2005, I don't remember the actual year, it was withdrawn from the market. The reason being that it was found to cause increased risk of heart attack. And people did die of heart attack whilst taking this drug, and it seemed to increase the risk of that. The reason this happens is because cyclooxygenase 2 isn't just expressed in type 2 activated endothelial cells.